All right, and we're back on. We're live. Thanks for coming in again, Dr. Leffler. I just got to read
Pleasure.
this real quickly. This is from the team. Welcome back to another malpractice case study review. I'm here with Dr. Marc Leffler, an oral maxillofacial surgeon and attorney who writes these case studies in his role as lead risk consultant at MedPro Group, a malpractice insurance company in our beloved profession of dentistry, and our partner for this series, these podcast series. So why don't we begin? And I'll pull up the case here on this.
So this is it's an unfortunate case of a 69-year-old woman who is diabetic, type 2 diabetic, takes oral hypoglycemic medications. She's also somewhat obese. She has a BMI of 32.4, and she's presenting to an oral surgery office to have some implants placed under what was told to her was deep sedation. And I'll kind of interject with my comments about deep sedation. I know that people like to group things definitively: light sedation, moderate, deep, general anesthesia. The way I view it is it's on a continuum. And you give a particular dose of whatever drug it might be to one patient, and they might be just staring there looking at you, waiting for something to happen. The same dose on another patient, and they're totally asleep, snoring away, no communication with them. But anyhow, this is the process that she was spoken to about. So she presents to the office, and it's an 11 a.m. appointment. She is NPO, despite the fact that she took her oral hypoglycemics, as she always does, at 7:30 in the morning. And she wasn't sure about whether to do that, and so she had spoken with the office prior and spoken to a receptionist, whoever the person was who picked up the phone, and she asked the question, am I okay with continuing to take my diabetes medication, even though I'm not going to be eating anything that morning? And that receptionist said to her, sure, that's what you're supposed to do. Take your medication as you normally would. You cannot eat after midnight the night prior. So she followed those instructions to a T. And I'd like to just throw something in there about office staff, non-dentist, non-oral surgeon office staff giving advice like that over the phone. And it's not an outlier at all.
This was in our last case. We had this in our last case, right?
Yeah,
Except it was an assistant. Yeah.
exactly. So what happens is that under general legal principles, the doctor is essentially responsible for the actions of those who work in the practice under him or her. So when that receptionist is giving advice, here specifically, take your diabetes medications, even though you haven't had anything to eat and will not have anything to eat for several hours before your appointment, that is giving medical advice. And that's something that should be left to the practitioner themselves rather than delegated to an office staff member. This kind of thing also comes up typically with postoperative complications or questions of complications. A patient calls after a procedure, is my site becoming infected? I have some swelling, I have some fever. Is it infected? And sometimes the office staff member who answers the phone will say things like, we see that all the time, don't worry about it. But those are important considerations. So from a risk management perspective, I think a thoughtful approach to take is that only the doctor should be giving advice about medical conditions, about medications, about side effects, about potential post-procedure complications. In this case, it turned out not to be an issue, but just as easily it could have. If the patient had a hypoglycemic event while in the chair, that's a whole other set of potential problems. But anyhow, in terms of what actually was critical to the case, is that we have two oral surgeons who are practicing together, both well qualified, have been doing it together for years. And their approach is actually very similar to the approach that I had with my partner when I was in oral surgery practice, which is, if possible, if we're both in the office, uh, when a procedure is being done with a patient deeply sedated or general anesthesia, the other one of the two doctors is handling the anesthesia while the other one is doing the surgery. Uh, Obviously, in some situations, if you're a solo or the practice is just too busy to allow for that type of situation, you can't do it. But it's a pretty safe way to go. We all know as oral surgeons how complex the issues of both surgery and anesthesia are. So it's tough enough to be monitoring one of them, no less monitoring both aspects of it.
Sure,
So
sure.
these two doctors working together. So one was going to function as the anesthesiologist and the other as the surgeon. I'll call the anesthesiologist just that, even though he, in fact, was an oral and maxillofacial surgeon. And he comes into the room. The office happened to be running behind schedule that day. Certainly not an unusual thing in any type of practitioner's office. So he comes in and very, very brief discussion with the patient. Hi, I'm the guy who's going to be giving you sedation so that you're comfortable during the implant procedure that we're going to be doing. Do you have any questions for me? No. Okay, good. Let's get going. And that's it. It might sound like a little bit of an exaggeration, but it's essentially what took place. The patient had completed medical history forms online through a portal system that they had. She had been provided with a consent form in the waiting room while sitting there for the few minutes she was before she got taken into a procedure room. Completed the form, signed it, and that was it. And there were no further discussions, although she did have a prior consultation meeting, but we're really not quite sure exactly what was discussed at the time. Continuing with the story, the doctor who was the anesthesiologist looked at her medical conditions and decided that she was an ASA class 2 patient, which is another area of subjectivity. What does it really matter? I don't know. I think when you get into a situation of litigation, if things don't go well, it might matter because you're going to be questioned on your judgment, determinations that you might have made based upon what ASA classification this patient was, or at least you thought that she was.
Would you give her a different classification? It looks like just hypertension that's treated and managed accordingly. Her A1C, I don't know
And
if we could we
so,
could call her diabetes control. But I'm sorry, what were you gonna say?
yeah. I mean, and let's not forget the fact that she was obese.
Thirty-two.
She's older. She was 69 at the time that she came in and presented to the office. I think you can go by a few concepts. Some people might be more conservative in how they would classify a patient, and some people would say, being diabetic, that's probably class 2 in most people's eyes. Being hypertensive, even reasonably well controlled, that's class 2. Being obese, probably class 2. So what happens when you put a bunch of those conditions together? Some people might say class 2 all the way. I have no concern with that. Some people might look at it and say, it's additive or even geometric when you have one condition piling up on top of others. So does it, just because you have all conditions which in and of themselves would classify the patient by most people's use of that system as a 2, is this patient a 3? Um, I don't know. It's, again, kind of a subjective assessment, but a lot of what is done in practice is a series of subjective assessments. And
And
I
that's
see that you have the ASA classifications pulled up, and I look at them periodically just when I'm reviewing cases, I don't know that there's anything in there that says that you should add one to the other and or consider a multiplicity of abnormal conditions into the mix.
Right.
But
It does just say under ASA 3, poorly controlled diabetes. I mean, like you said, it's subjective. We're teetering between 2 and 3, right? But this isn't like,
exactly.
but yeah, this isn't
Yeah.
like a 4 or 5 level patient. But um,
Right.
if I can just pause really quickly here, I
Sure.
just wanted to ask you 2 questions. Being that, for example, our last case came down to an assistant giving some advice, right? And then
Mhm.
this case is coming down to the receptionist giving some advice, potentially, substantiating in some form or another. How often does that come up in these cases, when it goes to court? And then that would be like part one. And then part two of that would be, how does that kind of weigh in with, say, who the blame gets put on? Because it's the doctor's license, right? It's the oral surgeon's license in this case that we're talking about, but the receptionist had some input that wasn't in the patient's favor, right? And
Right.
as we know, so yeah, if you can.
Yeah. To the first part of your question, how often? I think, at least intuitively, I think it happens very often that non-professional office staff give advice at various different levels, whether it's on the phone, in person, before the procedure, after the procedure. I think it happens a lot. I think that in terms of how often it plays a role in lawsuits and litigation processes, probably not that often, but often enough that sometimes when I do assessments of these cases, it's there, at least in the background. And the funny thing about litigation is that even if an action doesn't end up causing a problem in and of itself, the fact that it's there, that you can look at it and say it's in the background, might, at least in the eyes of a jury, put a little bit of grayness onto something that would either be black and white.
Mm,
Maybe there shouldn't have been involvement of that non-professional person giving advice. When they do give direct advice, that becomes really problematic. And I think that goes to the second part of your question. What's the responsibility? It all falls to the doctor. We have the
mm,
concept in the law known as vicarious liability, or it's a sort of a version of that. And the big picture is that the person who is in charge is ultimately responsible for what happens related to the procedure that they are handling. Whether it's a question of improper training of office staff so they don't automatically defer to the doctor when it comes up, when they come across something which is not specifically administrative, or it's actually they have been given specifically inaccurate advice, or it wasn't checked up upon, there wasn't an appropriate set of procedures in place for office staff.
mm.
So it can be any one of those things, but ultimately it comes down to the person who's in charge. The receptionist in this case becomes an agent of the doctor. So what they do falls to them. And
Yeah.
also that can also put a level of liability onto the office entity. So if they're an employee of the practice, which office staff usually are employees of the practice, then the practice as a separate entity might have
It's liable.
potential
I see.
liability. Yeah.
Right, right, because the training is predicated on the practice, not necessarily dependent on the practitioner. So now it kind of divides up the fault
Yeah.
in that sense. But okay, I see that one. One more. The second question I had was I noticed here both of whom are board certified, and I think this is really important because now we're in the middle of August, right? But there's, including myself and recent graduates from oral surgery programs, a lot of us are looking to take our part two boards, the oral board exam, and obviously most of everyone is taking it or has taken it. Where does this come into play? That it's noted both of these oral surgeons working on this patient were board certified. How does that play into the litigation process, and why is it important?
I think it's important because, well, at least from a litigation standpoint, I think it's in most cases, certainly not all, but in most cases, you're going to have experts who are serving in the case and who are going to be testifying before a jury. And they are going to be talking about their own personal credentials. And if you have a board certified expert against you who is talking about what his or her process was to get to that point where they became board certified, which is essentially the highest level that the profession can confer upon you, then if you are not board certified, it may not mean that you did anything wrong. For sure, there are plenty of very, very talented and smart non-board certified professionals. But again, in the eyes of a jury, especially if there is a savvy attorney on behalf of the patient plaintiff, they might point that out. Well, this person, this defendant, was not as well qualified as they could have been. They didn't go to that next step. So how do you, members of the jury, really know that they knew what they were doing? The expert knew what they were doing, but did the doctor who was treating the patient? So that's where it comes into play. And that's sort of background, if you will.
Noted. Definitely noting that. Yeah.
Yes. So, look, obviously these two oral surgeons in this case, they are both board certified. So they have gone through the rigorous process of training and board certification. They had the tools. They knew what they were doing. And according to the facts that underlie the case, they had been together for a good number of years, worked together on these very types of cases over and over again. So just moving ahead on the case facts, the surgeon does come into the room, and the quote-unquote anesthesiologist for the case had already been there, taken vital signs. Things were pretty good from a vital sign perspective, and goes ahead through an IV, gives propofol and Versed, and ready to go forward with the procedure. The surgeon comes in, and shortly after the medications are given, the patient's oxygen saturation drops. There is some labored breathing. She becomes tachycardic, hypotensive. It's clear that the patient is not doing well. She is desaturating. The oxygen saturation continues to drop over and over again. And she does not have a good cardiorespiratory status. It's quite clear. And unfortunately, and it was, I don't know if you want to call it abrupt, because there was somewhat of a downward progression, but big picture, it was pretty abrupt. A patient who literally walked into the office a short time earlier now unfortunately had this cardiopulmonary failure and passed away. And the autopsy determined that the cause of death was that cardiorespiratory failure from hypoxia during this dental procedure. And it's a tragic situation. It's a horrible situation for a practitioner to go through. And in this case, as certainly not unexpected, that there would be litigation that would follow. And in this case, because the patient had died, from a legal standpoint, somebody needs to be appointed as the representative of their estate. In this case, it was the patient's husband. He was appointed as the executor of the estate. And he, through attorneys that he researched and retained, began a lawsuit against both of the doctors, both the doctor functioning as the anesthesiologist and the doctor as the surgeon. So some unique situations here is that both of these oral surgeons had different malpractice insurance carriers. So sometimes in oral surgery offices, everybody has the same carrier. In other offices, they don't. So what is the difference? Well, it's about the policy that they have. So in this particular case, the policy that the anesthesiologist had was what's known as a consent policy. And I might have that backwards. No, but I think that's what it was. It was a consent policy. What does that mean? It means that if you're sued and you have such a policy, it's your determination as to whether you want to have your carrier try to settle the case. It's simply try to. You can't require that they settle it, but you give them permission to go ahead and try to do it. Whereas if you have a policy, which the surgeon in this case had, which was not a consent policy, he did not have any say as to whether his carrier was going to try to settle the case or not. So if a case is settled, well, then it's done. Money is paid and there is no trial. If a case is not settled, then the plaintiff has the obvious right, and in most cases, they'll just continue to plod forward and go to trial and see what the jury determines. Most of them are jury cases. So what happened in this particular situation, as in virtually all, is that the attorney for the executor of the estate, effectively acting as the decedent, was able to get an expert to say, in this case, two experts, well, that the doctor functioning as the anesthesiologist dropped the ball in a few different ways, according to this expert. And this expert pointed out to a few specific issues. This expert was of the view that the patient was on the ASA type 3 side. What significance is that? Well, his opinion was that when you have an ASA 3 patient, if you want to sedate them in the office, it should be a much lighter sedation than it would be for an ASA 2. Again, subjective, but in this world of litigation, that's the way it is. An expert testifies as to what their opinion is based upon their professional training and experience, and that's a position that a jury would hear. Countered would be the expert of the defendant doctor, the doctor who's been sued. They would have their own expert or experts who would say, for example, no, this was not an ASA 3 patient. This was clearly an ASA 2 patient. It was all appropriate what was done. This patient was appropriately worked up. She was appropriately monitored. The drugs given to her were within the appropriate amount, both in terms of dosage and with what frequency. All was done well. This is just a very unfortunate situation. Patient, yes, did pass away, but it was not because of negligence on anybody's part. It was a physiologic response that perhaps they would say could not have been foreseen or adequately foreseen. And it was not through fault. It was through a biological process that the patient ended up passing away. So that's the give and take, the yin and yang, if you will, in what that expert versus expert process is. So in this case, that was what the expert against the anesthesiologist was saying. The expert against the surgeon had a much less convincing approach. His approach was more of the workup wasn't great beforehand, that the surgeon was essentially the captain of the ship. So if the ship goes down, not to minimize it, but just as an analogy, if the ship goes down, for whatever reason, the captain is still responsible. And that was the argument in big picture that this expert was making against the doctor who was functioning as the surgeon here. So what happened was that the doctor who was the anesthesiologist, and I hope I didn't mix these up back and forth, but I'll make the point now, that doctor did not have a consent provision. So could not say whether he wanted the carrier to go forward and settle the case, but it kind of didn't matter. They were of the belief, the people with the insurance carrier, that there was strong evidence put forth by the expert for the plaintiff, which would be convincing enough in their eyes, putting a whole lot of factors together, having a lot of input, talking to their own expert, felt that this was a problematic case potentially. So they exercised their right to try to settle the case. The doctor ultimately agreed that it was probably in everybody's best interest to try to do that solely on behalf of him, not on behalf of the surgeon, different carriers, different work done. So this case was settled on behalf of the doctor functioning as the anesthesiologist. So that left the doctor functioning as the surgeon. The case had already been settled out for the what's known as the co-defendant. What to do now? So this doctor did have a consent policy and decided, no, I don't want to settle this case. I don't think I did anything wrong. I don't comment on what my oral surgery partner did or did not do. That's not my issue. But that case as against him was already settled. The patient or the patient's husband already got his money. And I don't feel that I should be contributing through my insurance company. And he took that stance. His lawyer said, we're not going to settle this on behalf of the surgeon. Let's go forward to trial. And what does sometimes happen is just as it's getting close to trial, sometimes you're literally on the courthouse steps or literally selecting a jury, and the plaintiff's attorney essentially backs out. No, we're not going to go forward with this. We're okay with just the settlement that we had from the one oral surgeon. So we're going to drop the case as against the doctor who was functioning as the surgeon, take what we already have, and end the case, which is what happened here.
I'm seeing that right here, down here at the bottom. I have it highlighted. My question is, this was, how do I call it? The plaintiff's counsel. So the attorney of the plaintiff, the husband of the patient that passed,
right,
was still going after the surgeon who was not performing the anesthesia, still wanted it under the guise of the capture the ship approach.
Right.
That's, even though it was two separate people in an oral surgeon's office, one doing the surgery, one doing the anesthesia, that's a pretty interesting take. Do you see that a lot?
Yeah, we do see it. I think it's probably more common in operating room scenarios in hospitals or surgery centers. But I don't see that the facility, the brick and mortar facility aspect of it really makes that much of a difference. Here you have, just like you would in an operating room in a hospital, you have two distinct practitioners. Like way back in my days of practice, we used to call it on opposite sides of the blood-brain barrier, a kind of a play on that, with the anesthesiologist being the brain and the surgeon being the blood, and the twain shall never meet. So that's kind of the approach that the plaintiff's attorney took here, at least to start. And I don't see that as being very unusual. Whether it ultimately goes before the jury in a situation where one of those two has already settled out, that's sometimes yes, sometimes no. It all depends upon how much money they are looking to try to get, what they've already gotten, what the mindset is of the people involved. For example, the husband. He's already been paid. Does he want to put himself again through the psychological traumas that trials just inherently bring to the forefront? Have to talk about his wife in public, those kinds of things. There are a lot of factors, and here it went to the benefit of the oral surgeon functioning as the surgeon.
As the surgeon, yeah. No, that's just it's so interesting how there's kind of a fight, I would say, between, I'm seeing a lot of CRNAs and anesthesiologists on the medical side of healthcare really fighting against the dental side to say that, hey, oral surgeons, especially specifically to oral surgeons, they're saying, hey, oral surgeons shouldn't be doing both the surgery and the anesthesia. And this case particular just surprised me, because even if we were to separate, there's only anesthesiologists and surgeons separately on every case going forward, say that was to become one day, the litigation's still just going to proceed where they file, lawsuits against both parties anyway, which really goes in the favor of either the patient or the loved ones of the patient. In a way, I understand how they want some kind of what's the word? They want some kind of like
Compensation.
compensation, making up for the mistakes. But I mean, how much did they say that the surgeon even began the procedure yet? I mean, do we know if he even walked in the room at that point? It was just the anesthesia part.
No, he had actually walked into the room,
Okay.
and it was really before surgery got underway.
Right.
So I understand your point that what ship was he captaining?
Yeah, exactly. And so, how do you see that? So that anyone could just file a lawsuit. Oh, the surgeon was in the room. Let's target him or her too.
Yeah, there's a concept, kind of colloquially, that lawyers might, at the beginning of a case, throw everything against the wall and see what sticks.
Yeah, yeah,
Uh,
yeah,
and it's not meant in a derogatory sense, so to speak, but at the beginning of a lawsuit, truly everybody knows less than what they ultimately will know by the time the case is ready to go to trial.
yeah.
It's just an inherent part of the whole process, because part of litigation is known as discovery, where you
Mm,
learn what the opposing side is going to bring to the table. So, and there are mechanisms, I think, to your point, during the process of litigation, where one party or the lawyer for that party might make a motion to the judge saying, Judge, there's absolutely nothing here against my client. Why are we even continuing against my client? I would like you to throw the case out against my client.
right.
That type of motion happens on a regular basis. Does it
Okay.
get thrown out all the time? No. Sometimes, yes.
Mm,
But I think your point is, uh, can a patient just sue anybody? Well, effectively, yes. Some states have rules with professional malpractice that before a lawsuit is started in this type of arena of professional malpractice, there has to be expert support from some that the lawyer speaks to somebody who is expert in the particular field and gives them the opinion in general terms. Yes, there's merit to this case. Some states require that expert opinion to be in writing, some don't, but the point is the same. There, generally speaking, needs to be some expert who says to the lawyer, yeah, I think you have a good case here that's worthy of pursuing.
right. Right. Can we I see at the bottom of this we have the takeaways.
Yep.
Let's go. Can we go just trace back through some of the takeaways? We don't have to go in this, the paragraphs in depth, but what are some takeaways that you would point out about the surgery? Obviously, we talked about this a little bit before with the ASA classification, although it has some degree of subjectivity
Yep.
to it, whether it's ASA 2 or 3, and how that's going to affect the sedations. I mean, obviously, higher ASA 3, you'd sedate them less. You'd want to keep them comfortable, but less deep, quote unquote. What's your comment on that? What do you think?
Well, my comment is that while the ASA does have fixed points, what they call, this is clearly a 2, clearly a 3, et cetera,
Yeah.
in practice, it's not such a clearly distinct fixed point. It's about assessment and judgment, and it's not. I'm not in a position to tell somebody, well, you should do X, Y, or Z with this type of patient, and you shouldn't do it with another type of patient. That's all about professional judgment. And essentially, each practitioner needs to feel comfortable with what they're doing from a technical standpoint and why they're doing it.
Mm,
And the why is important because you have to kind of say it. You have to look at every case as though it might end up in front of a jury if things don't go well. So that's
yeah.
why you have to have a rationale for everything that you are doing. And then you also need to be able to and should technically carry it out in the right way. The right way being in quotation marks, but uh, in a way that a reasonably prudent practitioner would carry it out. Of course, everybody has their own little nuances, surgical technique, but as
Yeah.
long as it fits within the larger scheme of what's appropriate, what's reasonable. Again, it's going to come down to one person's expert view, but they're not going to pull it out of the air, generally speaking. It's going to be based upon their own experiences, which, at least hopefully, ideally, are good professional training.
Another question for you, something I noted during our chat as we went through the case. Just propofol and Versed were used. Do we, by any chance, know? Do you know exactly how much of each was used? Because this is critical to the case, I think. You know.
Yeah. It's critical to actually the background of why things went where they were. I do not have the actual numbers here to be able to
Sure.
provide to you,
Yeah.
but I think the point that we sometimes like to learn from when we look at a case in the rearview mirror,
Yeah.
it's not so much the specifics. Was my conceptual approach to this reasonable? And even if a low dose of each was given, a dose, like I started out by saying, the same dose in two different patients, you might get totally different reactions.
True.
And perhaps a very low dose of each was given. But the reality is that the critical point is that this patient reacted, presumably very different from how the anesthesiologist practitioner anticipated, far different from what they anticipated the physiological response was going to be. And that's not something that you can always predict.
Yeah.
When I remember when I was in dental school in gross anatomy, my professor said sometimes the body doesn't read the book. So even though you anticipate something is going to happen, an anatomic structure is going to be here and not there. Well, sometimes it's there and not here. Sometimes a person will have a precipitous drop in oxygen saturation. And you look at yourself and you say, where did that come from? Why did it? It kind of doesn't matter. You need to be prepared to address it if it does. And some of it you can anticipate. Am I giving the right drug? Am I doing it in the right doses? Is it timed out appropriately? Am I titrating it appropriately? Sometimes you might look back on it and say, I did all of that stuff the right way. But you know what? The patient did not respond that way. And you take them as they come. They don't tell you how they're going to respond beforehand. So you need to be prepared to address the situation of what do I do now once it does happen. And that's I think that's another approach that probably, had this case gone to trial against the doctor functioning as the anesthesiologist, that probably would have been a big part of what the trial would have been about. What was the response? Were all of the appropriate medications, equipment available to be able to reverse what could be reversed, resuscitate appropriately? And I think those would have been delved into more, and we would have more of those details. But the case decides what details you have and what details you don't.
Right. Right. In the takeaway section too, another topic of discussion would be, it's this value of the consent to settle provision, where
Yes.
they both had two different policies, right? So
Yes.
one, Dr. M or Dr. G, the one doing the anesthesia didn't have consent to settle. So the malpractice cover, the insurer, or
Insurer. Yeah.
the insurer
Is the carrier.
the carrier makes that decision for that doctor who's doing anesthesia, versus the surgeon had the opportunity to say that no, he did not want to settle. And I think that's pretty interesting.
Yes.
You, looking back on your career, how do you think you would look at, would you prefer to have the option to get to consent to settle or not, or would you prefer the insurer, the carrier, makes that decision for you?
I think I'm the type of person, and I think it's probably not unique among surgeons. We like to control our own destiny as much as we possibly can, have as much control over the overall picture. So having a consent policy affords you a much greater level of control from a protective standpoint. You can just put your heels in cement and say, I'm not moving. I did nothing wrong. I'm sorry. I'm not settling this case. So that's,
Which is what he did, right?
yeah. I see. I look at it as an advantage to have that. If you, but and think about it though, if you didn't have a consent provision in your policy, and you have no choice, right? It's whatever the insurer and their internal workings lead them to conclude. They decide we're going to either try to settle this case or we will not try to settle this case and we're going to trial. That's if there is no consent provision. With a consent provision, so as I said earlier, you can control your destiny by saying, I'm not consenting to a settlement. We're going forward. Or you can say, for whatever reasons, I don't want to take time out of my office. I don't want the stress. But whatever reasons you might have, say, I really want you to try to settle this case. And you throw away your right to withhold consent. You say to the carrier, the insurer, please go ahead and try to settle. Now, then it's in their court whether they actually get there. They might feel, based upon our internal discussions with our expert, discussions with our lawyers, we don't think this case should be settled, in which case they will not. Or too much money is asked for, and they say, no way, we're not doing that. We're not going to reach that number, whatever it might be. So, but from the doctor's standpoint, you do get to control your destiny to a much, much greater level when you have a policy that has a consent provision.
Right. That does make sense. If that doctor didn't have that in the policy, do you think the insurer, the carrier, would have gone to try and settle it? Or would they have also dug their heels in the dirt, the concrete, and said no?
Well, I think based upon the facts that they would have gone forward and settled it. I mean, they obviously wanted to, based upon what they heard from the competing experts, their internal assessments, lawyers putting their views into it. There are also other considerations. During discovery, we have depositions. How did the doctor do during depositions? Did the doctor answer questions in an appropriate way? What's the demeanor? Was the doctor appropriately prepared to answer? Was there a sense of arrogance, or was it humility? Was there jury appeal? Those things all figure in. Again, a lot of subjective components, but defense lawyers, all lawyers, I think, are trained and develop a sense to be able to assess how a witness is going to appear in front of a jury. A very important component not to be overlooked in the mix with all the other underlying, more objective assessment components.
Yeah. This actually leads to, you brought up a great point. When the surgeon is put in the stand, asked a bunch of questions, their demeanor, their attitude, their body language sometimes too, right? For the surgeons and all dentists listening to this podcast, what would you recommend for what take should they have on the stand? Should they, or when would be the right time to display more humility? When would be the right time to display more stick to your guns, confidence? Hopefully not arrogance, but is there a certain time to have one versus the other potentially?
I think that there is, and I think that's still based upon the doctor's own inherent personality. So I would always tell my clients, I don't want you to try to be somebody that you are not, because it will shine through crystal clear and you will look like you're not being authentic. Jurors don't want to see that. But on the other hand, if authentic you happens to be a pretty arrogant person, they're not going to want to see that either. So the ultimate answer is that lawyers who do this all the time, they know how to assess their clients. They meet with their clients. They prepare them for deposition, for trial testimony. And if they're thorough about that preparation, they'll actually do a mock trial scenario with them, or do it however they feel comfortable doing it. But essentially try to replicate in advance what they anticipate is going to happen, see how the response was, and then being a fair broker about it, being candid with the client, saying, hey, I thought your presentation was great. You look like you're a caring person, you're authentic, Your knowledge base is really good. Let's keep it up. Let's bottle that. And that's what you bring to the table. On the other hand, if it's not that way, you say, I have to say that I don't think a jury is going to like that approach. It looks like you're taking the I'm always right kind of
Right.
feeling and approach to put before them. And nobody likes that, really. So we need to kind of bring you back to earth. Let's talk about how a typical jury in this particular jurisdiction is going to view you as a doctor. And can't change your personality. It is what it is. But we need to talk to you about how it can change the demeanor that comes through. We want, obviously, when a bad situation like this happens, you're going to feel horrible just as a human being. And a little of that showing through may be the right formula in combination with, look, I knew what I was doing. Here's what I did, why I did what I did. But that's something that really is worked out between client and attorney.
Oh, this is excellent. This has been a really good case to review, and especially from the oral surgery standpoint. For listeners, we alternate general dentistry or other specialties and then oral surgery. Since we are both oral surgeon, I'm interested in learning about oral surgery malpractice cases so that they don't happen to me and I know how to prevent them from happening. But this has been a great one. This has been really insightful and very interesting to see a case where different provider, not the oral surgeon, doing both the surgery and the anesthesia. I didn't know that this was common, that this happens out there.
Yeah, I don't know that it's common, honestly,
it's not common,
but it's in this particular situation, that's how it was. And it was just recently this week, somebody asked me, how is that possible that the oral surgeon is doing both the anesthesia, maybe it's light sedation, maybe it's deep sedation, maybe it's actually general, and also doing the surgery all at the same time. And it is not easy, and it is stressful, but such is the plight of an oral surgeon.
Yeah. What are your thoughts on that, of the oral surgeon managing both? Did you manage both? You said at your practice you had two doing each separately?
Yeah, well, what we tried to do was have, at least while the brunt of the surgery, the majority of the surgery was going on, one of the partners would come in, do the anesthesia portion, so the person doing the surgery could just focus 100% on that. Once it's done, you're suturing the site, patient is basically done, then they would leave and you'd finish up the case yourself. So we tried to do that, but admittedly, that was a generation ago. Things were a whole lot different. Their focus might be not amenable to doing that these days. What is my opinion about it? Well, at least from maybe it's a folklore kind of thing, but way back in the 80s, there was word of a study that had been done. I don't know if it's a formal study or not, which assessed the vital signs of the surgeon when the surgeon was doing both the surgery and the anesthesia versus when the surgeon was doing just the surgery. And the results were exactly as you would intuitively think, that when they're doing both, they're not as comfortable from a vital signs standpoint. I think that speaks volumes. Whenever we're stressed more mentally, emotionally, we get stressed more physiologically, and I think vice versa as well. So that's my thought on how that plays out. Whether it's realistic in practice, I don't know, and it's also not for me to say how somebody else should conduct their own practice.
Right. Huh. This is important to know. That's an interesting take on it. Yeah, it's definitely the more things on your plate, more responsibilities, more things you're thinking about, more stress, higher blood pressure, higher pulse rate.
Exactly.
It's all intertwined. This is great. Dr. Leffler, thanks. Thanks for going through this with me again today.
It's been my pleasure. I enjoyed it.
Yeah. So we'll do this, we'll do another one in a month, and I'll chat with you in email or text, whichever one's easier, and I'll send this off to the team, and we'll go from there.
Sounds great.
Enjoy your trip, and we'll talk soon.
Thanks very much. Appreciate it. See you next
congratulations
time.
On the you said it was 40-something years.
40 years. 40 years.
40.
Yep.
The big 4-0.
The big 4-0.
Congrats once again.
Okay. Thanks a lot. Take care.
All right. Have a good one.
You too.
We got a quick disclaimer, all right? Note that this case presentation includes circumstances from several different closed cases in order to demonstrate certain legal and risk management principles, and that identifying facts and personal characteristics were modified to protect identities. The content within is not the original work of MedPro Group, but has been published with consent of the author. Nothing contained in this article should be construed as rules for establishing a standard of care or as legal, medical, or dental advice, because the facts applicable to your situation may vary, or the laws applicable in your jurisdiction may differ. Please contact your personal or business attorney or other professional advisors if you have any questions related to your legal or medical obligations or rights, state or federal laws, contract interpretation, or other legal questions. Thank you.